my friends, and welcome back to another episode of To Your Health with Dr. G. Here we are on this great Wednesday night, bringing it to you live in full effect. I'm so glad to be back here, guys, on just a great episode. You guys have been following me all week on social media, and I'm so excited to kick this off. I've got two longtime great friends of mine, expert clinicians at their craft, and really we're talking today about surgical precautions in the COVID era. Yes, this era is still going on. We're still mired in the pandemic. And as we're opening up as a country, we're seeing more opening as far as medical care. And so I'm so excited. We're going to talk about it a little bit more. My name is Dr. 𝗦𝘂𝗶𝗰𝗹 Welcome back again. I'm a board certified internal medicine physician practicing out of Edward Hospital in Naperville, Illinois. You can check me out on my website, www.drmarkgomez.com. Also, I am a member of the American College of Lifestyle Medicine. I got to have my swag right here. There you go. So I'm just excited. So everybody, grab a pen, pull up a chair, relax, pour a hot tea, take some notes. As my pastor says, smart people take notes. And so really what we're here tonight is we're going to talk about really what's new. You know, when we think about surgery, we'll think of it this way. During a pandemic, total care does not stop. And if you didn't know, surgeries have been going on. But this show tonight is going to be talking about the elective surgeries. We might get into a little bit about some of the more emergent stuff that's happening right now and what we've had to do as a medical community, a medical profession, to change the dynamic of how we run surgeries now and make sure people are safe. But surgeries continue. Total health care does not stop at all. People have surgery for many reasons. Sometimes it's to ease pain. Other surgeries are done to treat a disease or help the body work better. Surgeons may also need to operate to look for problems. And in many cases, surgery saves lives, period. Some operations are performed certainly much more than other ones, and they vary in terms of condition that are treated and certainly with costs. So numerous hospitals across the country have returned to resuming performing surgeries, elective surgeries and other invasive procedures. And so again, we're going to talk about what's different now. And really the most important thing is like, why were these changes made? What can people expect as the new norm? And will they even care, and why they should? We're going to make the argument why they should care. And again, at the end of the day, we always have safety first. So again, welcome back, everybody. My name is Dr. 𝗦𝘂𝗶𝗰𝗹. You're going to meet my amazing guests in just a few moments. Before we get there, I want to hit you with a quick disclaimer. The content of To Your Health with Dr. G is for informational and entertainment purposes only, and that the content is not intended to be a substitute for professional medical advice, diagnosis, and or treatment. Further details can be found at www.toyourhealthwithdrg.com/disclaimer. All right, guys. So what I want to do is I want to introduce my amazing guests today. We're going to get right into it. You guys have come to expect everything. Before I just say something really quick, I had to give a quick shout out to my wife, Tiffany Gomez. Today is our 90th episode of To Your Health with Dr. G, really talking about building trust and delivering truth. We want you out there that's listening to leverage this, what we're talking about today, and apply it in your lives. Talk with your doctor. That's the most important person that you can talk to right now. If you have any concerns about your health and your well-being, your doctor's office is most likely open for business. Excellent. So I want to introduce my guest today. My first guest, he and I met in residency at Loyola. I was residency classmates with his wife, and just a really good friend of mine. I want to introduce you. He's been on my show before. I want to introduce my good friend, Dr. 𝗦𝘂𝗍𝗶, MD, FASA. Let me read his credentials. Dr. 𝗍𝗶 is a board-certified anesthesiologist. He is associate professor, Department of Anesthesiology and Perioperative Medicine. He's director of Preoperative Anesthesia Screening Clinic at Loyola University Medical Center. Follow him on Twitter. He's tweeting some really good stuff out there. I found myself. Follow him at Dr.M_O_O'Rourke. Check him out. Mike, welcome back to the show. How you doing?
I'm doing great. Thanks for having me.
Excellent. Mike, give us a little bit about Dr. 𝗍𝗶. Give us a little bit about your background. What did you do your medical school? Obviously, I dropped the ball and said you and I were in residency at Loyola around the same time, but give us a little bit more of your credentials and a little bit of opening remarks about what you think about today's theme, surgical precautions in the COVID era.
Sure. My background, I'm from Michigan. I went to medical school at Michigan State University. I trained for a year in Grand Rapids, Michigan, and then I moved to Chicago and completed my residency in anesthesiology at Loyola. And basically, since I finished there, I've been a faculty position there, and I currently work part-time at Loyola and part-time at the Hines VA, serving that population. As far as the topic, it's a very interesting topic, right? So anesthesiologists, in March, when recommendations came to kind of stop doing elective surgery, anesthesiologists became much less busy because a lot of us spend a lot of time in the operating room. So during the months, the rest of March, April, and portions of May, many anesthesiologists, rather than being in the operating rooms, were working in ICUs and other places helping to take care of COVID patients. And that certainly was the case for me. And now kind of in April, we've been shifting back and getting started again with care of surgical patients. So one of my roles at Loyola is I am in charge of the preoperative clinic. And so I've been involved in getting protocols set up for COVID testing and just general preoperative screening of patients there.
Excellent. Thank you, Dr. O'Rourke. Thank you. This is awesome. I'm so glad to have you back on the show again. I want to introduce my next guest. He and I were classmates together at Loyola, just a longtime friend of mine, a great supporter of what we do here at Dr. G. I want to introduce you to Dr. Matthew R. Schmitz, MD, FAAOS, FAOA, FAAP. He's a board-certified orthopedic surgeon. He's chair of the Department of Orthopedics, chief of Young Adult Hip Preservation Service. He's chief of pediatric orthopedics and adolescent sports medicine at San Antonio Medical Center. He's also associate professor at Uniformed Services University of the Health Sciences. He's also associate professor at Baylor University Clinical Orthopedics. He's also a team physician of the U.S. National Rugby Team. Check him out at Twitter, at RugbyMD. He's also on Facebook at Schmitz Hip Surgery. Dr. Schmitz, welcome to the show.
Hey, Dr. Gomez. Thanks a lot for having me.
You bet. Give us a little bit. Oh, sorry, I was going to say, go ahead and give us a little bit about your background and everything.
A lot of it right there, yeah. So you and I went to medical school together in Loyola, and then I came down to San Antonio where I did an orthopedic surgery residency. I then followed on and did pediatric orthopedics residency, and I've been back here in San Antonio since 2012, and recently became the chair of our department. So I'm really interested to talk about this topic tonight because, for one, I'm a clinician, a busy clinical orthopedic surgeon, but also as the department head, I was involved in the decision-making on when we started to shut things down, and then more importantly, kind of what I've termed the reawakening as we move into this next phase. I'm excited to be here tonight.
Hey, thank you, brother. It's awesome to have you. It's awesome to connect with you in this platform. Both of you gentlemen as well, too, longtime friends and supporters of what we do here at Dr. G. So thank you guys for taking time out of your schedules to help pass a message on to the general public about what's going on. So here we are. You just met my awesome guests. They're super fierce, highly skilled clinicians, and they're really decision makers in this process. They've both been intimately involved in making sure that your safety is the #1 priority. And that's never changed when it comes to your total care. Your surgeon, your anesthesiologist, they want you to have the safest and the best outcomes to that regards to your health care. So does your regular medical doctor. I can give myself some props too. But we want you to have the best healthcare experience, but we always want to be safe. And this time more than ever, we are being safe and safe and safe. We want it to be safe, seamless, and personal as well too. So let's get right into it, guys. You know, people want to know what's going on, so we're just going to get right into it. So hospitals are doing surgeries. And by the way, people that are out there tonight, again, things that we talk about today, talk to your doctor. But I've got this kind of framed as more like a frequently asked questions kind of scenario, but also these questions are for you out there, but it's a great time to ask the experts what's going on, but also to get their critical insight on how we are approaching surgical care in this day. So let me ask this first question to Dr. O'Rourke. Here we go. Here's a statement. I heard that my hospital system is doing elective surgeries. So are all surgeries being performed or just some?
Right. So that's a great question because things may be different depending on which hospital system, where you live in the country, and even like, for instance, in Chicagoland, which hospital you're talking about. So generally, you know, most states have, for a while, they put surgeries on hold. They're now a go in basically all states. There was never a time where we were not doing urgent or emergency surgeries, so those were proceeding regardless. But now we're talking about elective surgeries. So I was talking to a friend in Jacksonville last night, and he was saying, you know, we're a full go down here. Every room is running. You know, we're basically exactly the same as we were doing back in January. And that's because at the moment they have a low COVID population, so they're able to get going. But that may not necessarily be the case for everybody throughout the whole country. Areas that have been a little harder hit by COVID, like New York City and Chicago, the process is resuming at a little bit slower, and that's basically just to ensure the safety of patients and for medical physicians and nurses. So the question is my surgery a go? Those decisions are being made, and they're actively being revised all the time. So it would depend on what type of surgery you're having and where you're having it.
Thank you, Dr. Work. Dr. Schmitz, you know, you've been involved in really crafting this. I mean, you're running a department, but you're also making sure that your doctors and you yourself, when you are performing surgeries, are doing it in the best circumstances possible and safest for your patients, but not just for your patients, the clinical staff that are in the operating room with you and your colleagues, safety is there. So how did you guys go about designing this? And I always want to talk about this because this is important for people to know. You know, we take our health seriously. How did you guys want designing this process to kind of say, hey, you know what, now we're ready to go? Tell us a little bit about some of the work that went behind the scenes.
Yeah, so yeah, that's a great question. You know, the basic factors is whether or not your hospital system has enough personal protective equipment, and that's been on topic around. And so once you determine that you have enough, what we did is we created a multidisciplinary team that not only surgeons, anesthesia, but also the infectious disease doctors to say, how are we going to screen patients? Are we going to test patients? You know, which cases are going to be made priority? And actually a committee that decided when we first started opening which cases were given highest priority to go to the operating room. And we still aren't doing 100% of elective cases. There are some things just based on numbers. There are certain patients that have been triaged to the front of the line. And so it's really important that that's a collaborative effort, like most things that we do in medicine, with multiple different types of subspecialties involved.
Well, thank you. Thank you very much for giving us a little more of the insight on what's going on. And as you would probably echo Dr. Schmitz, let me ask you this question. What Dr. Work said, this process is being constantly reviewed and revised, correct?
Yeah, so we officially started doing elective surgery on Monday, 1 June, and we are meeting on every Wednesday and looking at our burn rate, how much of our protective equipment we're going to, how much we have in stock to see, can we continue at this rate? Do we need to slow things down, pick back up? We're at about 80% right now, but theoretically, can we increase that to a full 100%? So we are constantly looking at that with our team as well to make sure that we're resupplying what we're using.
Excellent. Dr. Work, how are we dealing with the backlog of patients? Because let's be honest, I mean, elective surgeries were put on hold and people may have had to put off their treatment for their ailment that's been plaguing them for a long time. How are we trying to undo that bottleneck effect? I mean, have you seen a bottleneck effect? And what's your take on that?
Right. So, I mean, that's a definite concern for anesthesiologists and surgeons all over the country. Is, you know, for some people, they have people waiting weeks or months to get in to see if they have an operation, and now with surgeries postponed several weeks or months, there can be a line of people. Now, I mean, the good news is generally what we're talking about right now is elective surgeries, which means there's not an urgency to them. So I want to really stress that urgent and emergent surgeries have been going on. If you have a broken bone, we've been doing those. If you've had cancer and needed an operation for it, those are continuing. For a strictly elective procedure, they're depending on your location, surgeons are restarting, but it's very important to physicians as well as to hospital systems that this is done safely. And what that means is you got to ensure, again, we're all social distancing. Hopefully everyone is doing that at their house right now. We are doing that in the hospitals as well, which means you need to ensure that patients in the recovery room, patients in the preoperative area, and nurses, that everyone has the space that they need. So, for example, when we started redoing surgeries, we started with kind of almost a soft open, meaning we were doing less surgeries than we would typically do just to implement the new processes to keep both the patients as well as all of our providers safe. So the backlog is definitely a real thing at some locations and for some types of procedures. As long as we're talking about an elective procedure, that it doesn't matter if it happens, you know, a week from now or 6 months from now, most people are okay with there being a backlog that will be addressed as soon as it is safe. But for patients who are having additional symptoms, anyone that would have harm come to them by postponing surgery, it's important that you talk to your doctor about that, because there's definitely the ability to do more urgent cases if it's needed.
Excellent. Dr. Schmitz, let's get right into this. I got to ask this question. I'm getting asked this question a lot by my patients. Do I need to have a COVID test before I have my elective procedure? What are you guys doing down there?
Yeah, that's a great question. And I think, you know, I like to borrow some of the words of our infectious disease specialist who's been heading it up, who says that testing really is the wild, wild west right now. And different hospital systems are doing different protocols. So what we've done at our hospital is 48 hours before an elective surgery, we are doing our test for COVID. Because the theory behind that is that there are reports and there's some questions that if you're an asymptomatic infection, that you could have worse outcomes from the anesthetic and things like that. Want to identify those patients. So everyone gets screened. They have symptoms. If they have screened, they're delayed. The elective surgeries get tested 48 hours beforehand, but we are not testing urgent and emergent because those need to be done either way. So I would say it depends on your hospital system. I know other hospital systems here in San Antonio are using antibody testing, and that's a whole conversation in and of itself. But we've decided PCR testing for elective surgeries.
I think that's what we're doing certainly in our practice, and we can go over some of the scenarios that I'm finding myself in, because now that I'm seeing more patients back in the office, I'm actually doing preoperative screening exams and clearance exams. What are you guys doing at your institution, Dr. O'Rourke? Are you guys requiring COVID testing prior to their surgical procedure?
Yes. Yeah, there's some national guidelines now that unless you are in an area with a very low rate of COVID infection where your patients are unlikely to be asymptomatic carriers, that testing should be done prior to procedures or surgery. So that is what we are doing. I mean, that's important because as we were just saying, that's important because if a patient has surgery and they have a COVID infection, even if they don't have symptoms, there's been one in particular good study from Asia that says if you have surgery while you have a COVID infection, even if it's asymptomatic, you are much more likely to have a complication from the surgery. So it's important for hospitals and doctors to know that you have if you have a positive test. So that's why my hospitals and really a lot of hospitals in the U.S. are testing for COVID beforehand to ensure that you're not putting a patient for undue risk by having a surgery.
I want to go back to what Dr. Schmitz said. Sometimes, you know, Dr. Schmitz, I'm quoting your local infectious disease expert who said sometimes the testing is like the Wild Wild West. What happens in that 48 hours before surgery? What are we advising patients to do? What if they're exposed? I mean, what are we doing to minimize those kind of risks?
And to clarify, it's because we're doing it 48 hours in advance. That's because with the batch testing, sometimes it can take a day to get results, and we don't want to delay cases. But what we're telling folks, what we have is you could have it done the morning of surgery, and you get a result within a couple of minutes. But what we're telling people is after that test that they need to go home and essentially self-isolate and not leave their home, because there is that concern that they could become exposed during that 48 hours before their surgery. So recommendations, we give them a one-page sheet that has a testing site, and then they're instructed to go home, not leave the house, don't go out to eat, and isolate from there for 48 hours before surgery.
Say that person, I'll ask this question, Dr. O'Rourke, say that person tests positive, they get that 48-hour screen, comes back the day before their test, it's positive. Are we aborting things right there and then rescheduling down the road? What's the protocol?
So that definitely, again, depends on the type of surgery we're talking about. But because doing an elective surgery while you're COVID positive puts the patient at risk for having complications, for a purely elective procedure, it's likely to be postponed. But I would definitely say that basically at our institution, that triggers a conversation between the surgeon and the patient regarding what the best plan then is. So I wouldn't say 100% like your surgery is going to be canceled, but going ahead with your surgery does likely put you at increased risk. So that would definitely be a conversation you want to have with your doctor if you tested positive.
I've been in that scenario recently. I had a gentleman who was seen for a shoulder surgery on his rotator cuff. This is several weeks ago, and actually his physician had ordered a rapid test to be done the day of surgery. So he gets the pre-admission, they rapid test him. Of course, he's positive, abort the procedure, and now you have an unhappy person who had his spouse take him and all this kind of stuff. And I kind of reached out to the doc, and I was like, what's the protocol? Because I think it's great that you guys have a very well-oiled machine kind of protocol, but there are still some medical groups out there, hospices that may have not established that yet. I know what we did for this particular case. We certainly aborted the procedure and actually sent him for a true nasal PCR test after 2 weeks, though. We retested after 2 weeks. We thought that test might have been a false positive because actually that guy had been self-quarantined for several weeks, maybe even several months at that point. But it gets into those kind of nuances of things. So what do you do? What are you guys doing, Dr. Schmitz, for you guys? I mean, are you guys maybe say somebody tests positive and maybe somebody's persistent? Would you try to run the test on another analyzer? Would you try to see, would you put on another machine and see if it comes out positive still?
Yeah, I think that, in that situation, we would delay the case. And if they never showed symptoms, delay it between 2 weeks and test them again. And then if it becomes positive again, then maybe try a different method. I think that, Dr. O'Rourke kind of hit on it. We are only testing purely elective cases. And so we've kind of taken the stance that if you're positive, that elective case can be delayed for 2, 4, 8 weeks.
Excellent. Well, thank you. All right. So here's a question. A question from a common question I can ask, a question from the audience. This is for Dr. O'Rourke. Will I be safe in the hospital if my health system is treating proven or suspected COVID-19 patients? So they're going in for surgery and there's COVID patients in the hospital. Will that person who's getting the surgery be safe?
That's a great question because, of course, prior to February, no one has. These are all evolving things. So I can't point to evidence. I can give you my response, but I can't base that on evidence because this is brand new. So many hospitals that have COVID patients are primarily isolating them in particular floors. So certainly if you are COVID positive and you have surgery, you would go to a floor that has COVID positive patients. And, ICUs and other floors, hospitals are being very meticulous about ensuring that anybody that has COVID or is at risk of having COVID is not interacting and not on the same floor as those without it. So I cannot quantitate, I can't say, oh, your risk is this or your risk is that. I mean, certainly me getting up and going to the hospital every day probably puts me at more risk than if I was staying home, right? So if certainly having surgery and going to a hospital is going to put you at increased risk. I can only say that hospitals and doctors are doing everything they can to prevent the spread of this disease and to protect patients.
Dr. Schmitz, are you finding any pushback at all in your practice? You're advising somebody to get surgery, they're struggling with their ailment. Are you seeing some pushback from some patients say, you know what, doc, even though I've been dealing with this for 6 months or whatever, I'm going to hold back? Or do people even ask you like, hey, am I going to get COVID if I'm in the hospital?
Yeah, that's a great question. I think there's kind of two flavors of patients. And there are some patients that are very scared of entering a hospital, and everyone, we've seen numbers decrease for clinic and follow-up and things like that. On the other hand, there are people that have been for a long time. My dad just had his knee replaced 2 weeks ago, and he said, I can't anymore. You know, it had been scheduled for, so I think both flavors, and it's important for you to discuss with your doctor, if with your surgeon, if you're having hesitations and it's purely an elective surgery, then delay it until you're comfortable, because it's not just the surgical encounter, there's the rehab afterwards. And if you're not comfortable going to the hospital or going to your doctors for surgical visits, are you going to be comfortable going to rehab afterwards? So all that is encompassed in it.
Wonderful, thank you. Let me ask a question to Dr. O'Rourke. Since you're running the pre-procedural clinic at Loyola, I want to ask you this question. This is a question that's come in. Here we go. My doctor has advised me to undergo elective surgery. Here's a question. Do I need to go for a preoperative assessment? And if so, what is involved and why is it important?
Right. So that would definitely depend on the patient and the type of surgery you're talking about. So many surgeries are done where you go in and have surgery and go home the same day. A lot of times those are low risk procedures and you don't really need to get testing beforehand. There's other, you know, that's one end of the spectrum. The other end of the spectrum would be maybe I'm having an open heart surgery or some other major cancer surgery. And oftentimes those types of surgeries do require testing. So when we think about preoperative testing, there's two things that influence what tests you need. One would be the patient and what medical conditions they have. There's some testing that might be needed, for instance, if you had diabetes, either preoperatively or on the day of surgery. And then the second portion is what surgery are you having? So, so it depends on those two things. And again, I'm very familiar with my hospital system, but there are a variety of models for preoperative testing throughout Chicago, throughout Illinois, and throughout the country. In my personal opinion, it's always a good idea to see your regular doctor, your primary care doctor, before you have surgery. But many different people may order tests for you. Your regular doctor can order it. Your surgeon can order it. And there are hospitals and hospital systems that have preoperative clinics where you go and actually have tests ordered there. So it kind of depends on what surgery you're having and what hospital system you're having it in. But generally, you know, your surgeon can guide you through their particular hospital system and what type of testing to expect.
I know for me as a primary care physician, I want to have a touch points with my patients. So all my patients that need elective surgery, at least the surgeons that I know, they know that they're going to see that the patient's going to see me. Obviously, if it's an emergency surgery, that's a different story. But if it's an elective procedure, they're always going to touch base with me again. I want to make sure that I'm quarterbacking their care, but it's also good connected with them. We know surgery it can be very worrisome, it can be scary for people, it can be anxiety provoking. And I think sometimes seeing the person that you see most commonly can kind of give a little calming thing, especially in these times. And I've already had to ask some answer some COVID type questions for my patients out there. Let me ask this question for Dr. Schmitz. All right, here we go. Patients, no, I like this one. Here we go. Can my family or friends come to the hospital on the day of surgery or to visit me in general? What's your guys' take on that? I'll start with you, Dr. Schmitz, and then maybe we'll ask Dr. O'Rourke.
So like a lot of things that we're talking about, it really depends on the facility's policy, because different hospitals have different policies. As a surgeon that operates on children, we are allowing one parent in the room right now. And so, and we're usually allowing one visitor as well for our adult patients. But I know that there are other hospitals that are not allowing visitors at this time. Something that I would check with your surgeon and check with the hospital, because again, this is what in June 3rd, 2020 may not be the case June 18th or June 30th. And so these are all evolving things.
Dr. O'Rourke, what's your take on that one? Generally speaking, would you concur with Dr. Schmitz?
Yeah, I think that's an excellent point, that these things are definitely evolving, because, February, you could have, at some places, you could have your whole family, come in and sit with you in the preoperative area. Yeah. And now it's a very short period of time later. And in fact, no one might be allowed. Again, this is, as he said, it's definitely dependent upon your hospital system, and it's something that most hospitals, because this is a change in policy, are doing a good job about calling patients a day or two before surgery to let them know what expectations should be. But because some patients need ride home after surgery, and definitely you want to have your support system in place preoperatively, including the morning of surgery. So that's definitely something I would, again, check with your surgeon so that you have a clear idea of who can be with you on the day of surgery.
Thank you. Dr. Schmitz, I want to ask you this question. Since you're doing a lot of stuff and doing the surgery and working with other doctors, other surgeons in your department, generally speaking, what precautionary measures are being taken in the operating room itself in the COVID era when compared to pre-pandemic measures? Are you guys doing anything different to get yourselves ready before you actually operate?
Yeah, so kind of two different sides to that is what is anesthesia doing and then what is the surgical team doing. And so we know that the highest during aerosolized generating procedures, specifically in intubation. So for that, our anesthesia crew is using full PPE, face shields, and then we're actually clearing the room and allowing for kids to go by before anyone else in the room comes in. And that's based on the number of air exchanges in our specific ORs, that 99% of any particle out in 20 minutes. So we're adding 20 minutes at the beginning of every case and then 20 minutes post-extubation to try and keep as many people as safe as possible.
Thanks, Dr. Schmitz, on your take on that one. Dr. Owhork, from an anesthesia standpoint, are you guys doing similar processes out there?
Yep. Yep, for sure. So we've been talking a lot about how COVID affects the patients, but it definitely also affects everybody in the operating room. And for me as an anesthesiologist, not all cases require a general anesthetic and require an intubation, but many of them do. And that's one of the highest risk procedures for people that have, for patients that have COVID, for transferring that COVID to the anesthesiologist who's doing the intubation. So generally, anesthesiologists are wearing full precautions when they're doing intubations, simply to protect themselves from possible infection. And yeah, and it also depends on the type of surgery you're having. There are certain procedures where many people in the room may all be wearing them. There's different protocols. But so it may be just the anesthesiologist team, since they're the ones doing the intubation, or in fact, everybody in the operating room, depending on the type of surgery, may need full PPE.
Wonderful. Here's a question coming in. I like this one. This is for Dr. Schmitz. Does the current COVID-19 situation change my length of stay after my surgery or procedure?
So at our hospital, it hasn't changed the length of stay. We generally try to get our patients, if you're having a same day surgery, you go home the same day. If you're having an inpatient stay for a bigger procedure, general rule of thumb is we'd like you to leave the hospital as soon as possible, because there's all kinds of risks of being in the hospital. And so this hasn't specifically, unless there's a complication, but the COVID era hasn't changed the length of stay in the hospital for us.
Thank you. Here's a question, Dr. Owhork. I like this one coming in from a listener. Does surgery itself make me more likely to get COVID-19?
Excellent question. And again, I like to base my answers on data, and there's not a lot of data to answer if surgery is going to make you more likely. I might go back and just say, certainly if coming to a hospital or come to a surgical facility and interacting with people, if there is COVID in your community, is certainly more likely than if you're staying at home. How much of a risk it is to come in and have surgery, that's really not known. I can't really speak accurately on that.
Well, I think you both have laid the case that you're this for people out there to understand that your hospital system, your doctor, your surgeon, they are making sure that you are in the safest environment, period. And I cannot stress that anymore. This is just like we would have in the pre-pandemic era. We wanted to make sure that you were safe and well taken care of for you and your loved one. I don't think that's changed. We just got a couple of things now. We're certainly a lot more in tune, but we were already in tune. But certainly with this heightened uncertainty with COVID, we don't want to leave anything to chance. If again, here's the next question. I like this one for us. This one for Dr. Schmitz. Here we go. Here's a statement. I was already cleared for surgery pre-COVID, but it was postponed because of the pandemic. Do I have to repeat all my pre-procedural testing?
That's a great question, and I'll echo what Dr. O'Rourke said yesterday. It really depends what your health status is. If you're a relatively healthy person and nothing has changed in your medical history, maybe not. But if you have significant heart disease, significant comorbidities, and it was 90 days ago that you had your EKG and testing, then it's probably best that get looked at, especially if you haven't been active and maybe things could have gotten worse for you personally during this time frame. So I would kick that to Dr. O'Rourke, and I would ask our anesthesia colleagues and our pre-anesthesia folks about what they would recommend.
Excellent. Dr. O'Rourke, what's your take on that question? Do they need to repeat all their pre-procedural testing?
Right. Most likely, no. But it depends what tests we're talking about. Generally, LAD, EKGs, those things, if they've been done within the last 3 to 6 months or even up to 12 months, there's no need to repeat them. But it is very important if there have been changes in your health, then additional testing may be needed. So if your surgery I would say for the vast majority of people, no, tests will not need to be repeated. But depending on the type of surgery and your specific medical problem, certainly the full gambit of tests would not be needed to be repeated, but some might.
Yeah, I know what I've done, and I've had some people, and now I'm getting into this scenario because we had some people that were scheduled in mid-March, right around the time when things were shut down completely. I've actually just had a chance to reconnect. So I've actually openly, as a primary care doc, I've actually invited those people back in. Let's reassess things because we've had a little bit of lag time, and it's different than like maybe some of the virtual connections because I might get some stuff that'll say, hey, they'll send me a message, Dr. G, I'm doing all right. But I'm like, no, I still want to get an objective assessment on you. But that's just me. That's how I choose to practice. For you guys out there listening to us, you talk with your doctor. This is where you and your doctor have these critical decisions along with your surgeon to make sure everybody's in the loop. Here's the next question. I want this question. Go ahead.
Sure, just to reiterate what you said, for sure, the world is a different place now than when you originally scheduled your surgery. So certainly reconnecting with your primary doctor and just kind of talking about where you are now and your concerns about surgery may be completely different now than they were 2 or 3 months ago. I think definitely reconnecting with your primary doctor is always a good idea.
Plus, I miss my patients anyway, so that's why I want to see them again. We'll do a couple more questions, then we'll get into some myths versus facts. I love this discussion, guys. Here's another common question that's asked, frequently common question. Here we go. This is for Dr. Schmitz. Can I postpone my surgery until the COVID-19 crisis is over?
I would tell that for elective surgeries, yes, you can. For an elective surgery, you should be the one deciding when to have that, when it fits into your lifestyle, when it fits into your timing with your family. Obviously, there's things that factor into that. Summertime is a busy time for us for elective surgeries because kids are out of school, people can take vacation. So if that factors in, but you should be the one that decides that. And because what I tell my folks is I can't tell you how bad this is bothering you. We can correct it to try and help your pain, but you have to be the one that decides when it's time. So of course you can delay.
Excellent. What's your take, Dr. O'Rourke? You would concur?
I would 100% agree. I wouldn't want patients to delay care or surgical care that would improve their health. But generally, a patient needs to be comfortable with coming to the hospital and having surgery. And I think having it when you're ready for it is optimal.
Excellent. I want to get into a little bit more of a challenging question. I've been put in this situation myself, but I just easily punt the question over to my surgical colleagues and say that they are still highly skilled. But here's a question that I get asked, and it's a legitimate question to ask. So I'll ask this question to Dr. Schmitz. Here we go. Here's a lead-in. My surgeon's office has been closed for a few months. Should I be worried at all that my surgeon has not performed my type of surgery during that time?
No, you shouldn't be worried. I mean, we like to joke that it's kind of like riding a bike. And to be honest with you,
Love it.
surgery skills it's a whole gamut of skills, and we've been operating. We've been doing emergency surgeries. I may not have done any ACL reconstructions in the last 3 months, but I've done 1,000 of them over my career, and so that part's not going to be hard. We've looked at this from a military standpoint. There are some people that deploy for 3 or 4 months and don't do a lot of surgery, and they come back and they don't really have a significant skills deterioration in that short amount of time. And so when you go the number of years that most of us have been operating, taking a little 2.5 month break isn't gonna make or break it for us.
I love that riding the bike analogy. Again, and that's why I think when I get asked that question, I go, I just tell my patient, I go, your surgeon has done literally 1,000 of these. They are highly skilled. You don't have to worry. I try to nip that in the bud. But let me flip the question a little bit, because both of you guys are involved with academia. You both are involved in teaching residents, medical students. How does this delay affect future care of patients and the people that you are training? I'll ask the question to Dr. O'Rourke first, and then I'll have Dr. Schmitz elaborate.
It probably has a big impact. So medical students and residents are a little different. Medical students mostly across the country were generally not in hospitals while the COVID patients were there. It was thought that, putting those people at risk was not ethical. So generally medical students have been absent from a lot of large academic hospitals. Not every single one, but a lot of them. Residents have still been training. Certainly for surgical specialties, anesthesiology residents, and surgical residents, certainly their workflow has been different because it's not like you were doing, because the number of surgeries have been less. But in my personal opinion, that will be adjustments made by their programs moving forward, but it's not necessarily a bad thing. I mean, this has been a major impact on healthcare that all physicians have had to react to, and residents are really no different. And it's really been a big learning opportunity for me, for other anesthesiologists, for healthcare systems, and certainly for our residents who are training.
Dr. Schmitz, please give me your thoughts on this one.
Yeah, I agree. I guarantee that ACGME and our different subspecialties are going to really look at this, because I personally don't think it's going to have a huge impact. Again, when you talk about, for example, orthopedic surgery is a 5 or sometimes 6-year residency, a 3-month break, people take 3-month breaks for health reasons and things like that. What we do know is that so for orthopedics, there are case minimums that your residents have to reach to be able to graduate. Now, all of our chief residents had met those already. But what we're going to have to look at is, as we go forward another couple of years, did this impact the case minimums on some of the more rarer cases for certain residents? And that I can't answer for you. I'm hopeful, in speaking with my program director, we're hopeful that it won't affect it, but we may have to make some modifications to resident schedules to make sure that if they missed 3 months of a spine rotation and it was the only time they were going to do spine during a 3-year period, then some changes are going to have to be made.
Wonderful. I appreciate both of you guys keeping it real honest with that one. Let's get into some myths versus facts. So everybody out there that watches the show, on my 90th episode, again, we do something every week called myths versus facts. It's all about setting the record straight. Again, building trust and delivering truth. How it works, I'm going to say a statement, and my panelist is going to say myth or fact. They're going to explain why. We're going to kind of go bam, 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 keep this thing moving, and we'll see how many of these we can get in there. Myths versus facts. I love it. So here's the first statement. Dr. O'Rourke, here we go. Here's a statement. Myth or fact? Health systems nationwide will likely continue to be affected by COVID-19 for many months to come.
100%, that's a fact. I think it'll be different than it was when it first hit, but certainly at my hospitals, we have COVID patients in the hospital right now, and I think that's the case for many hospitals throughout Chicago and the country. So these are patients we're taking care of, and the disease is not going to go away. So it will definitely be a problem that we're continuing to deal with, and we'll continue to treat patients with that disease. That being said, like specifically for surgery, when all elective surgeries were stopped in March, that was because of a lot of concerns, including the PPE and ventilator issue. I don't think those issues are likely to recur, even if there is a surge in the summer or fall, as some people think there are, because now, you know, we have many hospital systems have plans in place if those are to occur, and we're a little bit more prepared. So I wouldn't expect an interruption in surgical care as occurred in March, but I personally expect to continue taking care of COVID patients probably into 2021.
All right, thank you. Here we go, Dr. Schmitz. Here's a statement. I was already diagnosed and resolved my COVID-19 infection. I still need to undergo, I still need to undergo COVID testing prior to my surgery. I guess that gets to the question again, does everybody still have to get a COVID test?
I think that's it depends on your hospital system. At my hospital system right now, it'd be a fact, but it depends on your hospital system.
Excellent. I agree with you on that one. Yeah, it would be a fact in my system too. Here we go, Dr. O'Rourke. I like this question. Oh, go ahead. Go ahead, Dr. O'Rourke.
Well, one interesting thing, as testing has become more available, there's some question as to once you've had it and you've tested positive, then if you retest, some people, for whatever reason, keep shedding a small amount of the virus and can be positive for weeks afterwards, even when their symptoms have resolved. So that's a really interesting question. And it's like if you test positive a month after and you have no symptoms, whether that test means anything is an interesting medical question right now.
I like to leave let my infectious disease colleagues always go on that one. Awesome. Love this one. Here we go. Dr. O'Rourke, I'm coming right back at you. Here's a statement. My primary care physician must approve my surgical procedure. Myth or fact?
It depends. Depends on your health insurance, to be honest. I would say generally, no, strictly speaking, that's a myth that your primary physician doesn't need to specifically approve it. I would, as I think we said a couple times already, it's definitely a good idea to see a regular doctor and let them know that if you're having surgery so you can be prepared for it.
I think my patients that know me know that they got to come in and see me before their elective procedure. So if that's an approval, it is what it is. Excellent. Dr. Schmitz, here's a statement. I like this one. All right. It is okay for me to postpone my surgery. We just did this. It is okay for me to postpone my surgery until after the COVID-19 crisis is over. Myth or fact?
That's a fact. You need to be comfortable with getting the health care, and you need to be comfortable with having your surgery. So you can postpone it as long as you want, as long as you're not physically deteriorating from your condition.
Excellent. Here we go. Dr. O'Rourke, I like the system. I like this question. Sorry, not the system. I love the system though. Here we go. I will get in-hospital transmission of COVID-19 during my surgical stay. People saying they will get it during their surgical stay.
That's a myth. Hospitals are doing everything in their power to keep COVID patients and non-COVID patients separate. And certainly many surgeries are done where you come in and you go home the same day. So if you were likely to get COVID while you were having surgery, I don't think any physician, surgeon, or hospital system would do surgery. So certainly systems are in place to prevent that.
Thank you. Here we go. Dr. Schmitz, I think this will do a couple more. I will be required to wear a mask during the continuum of my surgical stay. Myth or fact?
That is a fact. I have to wear a mask to walk in from the parking garage to the hospital. So everybody that's in our hospital has to wear a mask. Now, there are certain times when you're in the recovery unit after your surgery, they're not going to make you wear a mask. But during your hospital stay, we are making the patients wear masks to try and protect various people. So yes, fact.
All right, thank you. Here we go. I like this statement, Dr. O'Rourke. All right. If you do not complete all preoperative testing, then you will not get surgery. Myth or fact?
Preoperative testing is designed to either optimize you or to evaluate your surgical risk. So certainly I would encourage anybody, if someone recommends they get some type of preoperative testing, to have it. Whether or not it absolutely would prevent you from getting it if you don't want to get it would be a conversation you would need to have with your physician.
Wonderful, thank you. And I like this last one. Here's this for you, Dr. Schmitz. Here's a statement. Health systems will coordinate the details of your drop-off and pickup with your support person before and after your surgery. Myth or fact?
That's a fact. That's a fact. Our perioperative folks have been absolute all-stars. You know, we switched from having this massive in-person pharmacy that seemed to always have a two-hour wait to a drive-through pickup pharmacy on orders of a day, you know, and so our folks have been absolutely wonderful in coordinating your perioperative medications, making sure that you're getting wheeled down to your partner picking you up, and so that's an absolute fact. The hospital's going to do everything they can to make sure that you have a great experience and a healthy experience.
Wonderful. There you go, guys. Thank you again. Myths versus facts. Love it. So we got about 5 minutes left, guys, and I certainly appreciate both of you guys, Dr. O'Rourke and Dr. Schmitz, for coming on today. So what I want to do is I want to wrap things up, but I want to leave people with some take-home points. So let me start out with you, Dr. O'Rourke, and here's the statement. Here's kind of the question. What should people understand about the surgical precautions this day and age in this COVID era? What are some, maybe a couple, 2, 3 take-home points for people to understand out there that are thinking about surgery during this COVID era?
Sure. One would be, you know, the coronavirus testing is new. It's new because we've never done this before. So it's a new process. There may be some bumps in the road if you're having surgery with your testing in the next few weeks, but I would suspect, like anything, it's a system that's being ironed out, and hence I think it's going to be here for certainly a few months, and it's a system that's really getting smoothed out at most hospitals. So be patient with your physician, but it's a work in progress. The second would be just generally for preoperative assessments. These are designed to optimize your care perioperatively. So make sure you touch base with your regular doctor and your surgeon about, you know, what the protocols are, whether you're going to just see your regular doctor, if there's a clinic you need to see, to make sure that you're ready for surgery, and make sure you ask questions, you know, about your recovery period for what to expect. And I guess finally, I just give a plug to my anesthesiologist colleagues. We've been really involved with the care of COVID patients in the hospital over the last couple months, and that has been both anxiety-provoking and exciting, and we're really looking forward now to shifting to getting back to taking care of people in the operating rooms.
Wonderful. Well, thank you, Dr. O'Rourke, for sharing your insight on such an important topic. Dr. Schmitz, give me a couple take-home points. Give me 3 take-home points or so that people should understand about these surgical precautions and what we're doing to make sure that they're safe in this COVID era.
Yeah, sure. So number one, I think it's really important to remember that your whole healthcare team, from your primary care physician to your surgeon to anesthesia, it is their ultimate goal that you have a wonderful experience and improved and better outcomes. And so everything that we're doing from the meetings that I attend are to make sure that we keep our patients safe. Number two, I would remind patients that things are moving a little bit slower than usual right now. We're encountering bumps in the road, as Dr. O'Rourke said, and we're trying to figure those out. And so, you know, surgeries aren't happening with 15-minute turnover times. Things are moving a little bit slower, so be patient for that. Same thing with in-person visits in the clinic and virtual visits. And then number 3, remember that right now at the beginning of June is not what things are going to look like at the end of June or at the end of July, or even next spring. There's going to be more changes, and there's changes that we are unable to predict right now. And so it's incumbent on us as physician teams to really try and look at the data and make sure we're making the best decisions for our patients.
Wonderful. Thank you again, Dr. Schmitz, for sharing your thoughts. And my final thoughts are this: the safety of our patients, families, staff members, and community have always been there. They've always been a top priority, and they still are now more than ever. I recognize that our ability and our responsibility in caring for our patients goes beyond their physical health. If you or your loved one are advised to have surgery, continue to talk to your surgeon, ask honest questions, and receive honest answers. And know that we've got your back 100% to keep things safe, seamless, personal, just as you would expect during your time of healing, recovery, and beyond. I want to thank my guests today. It's been great to check in with them again. Dr. 𝗦𝗂𝗏, MD, FASA, board certified anesthesiologist, associate professor, Department of Anesthesiology and Perioperative Medicine, director of Preoperative Anesthesia Screening Clinic at Loyola University Medical Center. Check him out on Twitter at Dr.Dr.M_O'Rourke. My other guest today, longtime friend and colleague, Dr. Matthew Schmitz, MD, FAAOS, FAOA, FAAP, board certified orthopedic surgeon, chair, Department of Orthopedics, chief, young adult hip preservation service, chief, pediatric orthopedics and adolescent sports medicine at San Antonio Military Medical Center, associate professor at Uniformed Services University of the Health Sciences, associate professor at Baylor University Clinical Orthopedics, team physician, U.S. National Rugby Team. Check him out at Twitter at RugbyMD. Also check him out on Facebook at Schmitz Hip Surgery. Hey, you guys have been listening and watching live on Facebook. This episode is written by Mark D. Gomez, MD, and Tiffany E.R. Gomez. Producer is Tiffany E.R. Gomez. Music is by the wonderful Mr. Havis. Copyright 2020 by MDG Wellness LLC. All rights reserved. Hey, everybody, stay tuned for my next episode next week. The title is Workplace Safety in the Era of COVID-19. Thank you, guys. Have a great night and peace.